Good afternoon, everyone, and welcome to the Stanford Healthcare ENT Experts Up Close webinar. Today's activity is titled Latest Advances in Rhinoplasty and Sinus Surgery. My name is Lynn Johnson, and I'm the Market Outreach Executive Liaison for the Stanford Healthcare Otolaryngology Head and Neck Surgery Service Line. So our speakers today are Dr. Sam Mose, a professor in the Department of Otolaryngology, Head and Neck Surgery, and Plastic Surgery at Stanford University School of Medicine. He serves as Chief of the Division of Facioplastic and Reconstructive Surgery and Director of Stanford's Fellowship in Facioplastic and Reconstructive Surgery. His clinical practice focuses on functional and aesthetic surgery in the face, including rhinoplasty, facelifts, eyelid surgery, and skin cancer reconstruction. He has published extensively across these areas. Also speaking today is Dr. Zara Patel, the Director of Endoscopic Skull-Based Surgery, Director of the Stanford Initiative to Cure Smell and Taste Loss, and Professor of Otolaryngology and by courtesy of Neurosurgery at Stanford University. Dr. Patel is an expert in advanced endoscopic sinus and skull-based surgery. She treats patients with a wide variety of rhinologic complaints, including those with chronic rhinosinusitis, sinonasal and skull-based tumors, and olfactory disorders. Dr. Patel has published widely on topics such as precision medicine and chronic rhinosinusitis, new devices and techniques for endoscopic skull-based surgery, predictive criteria for behavior in sinonasal tumors, artificial intelligence, and olfactory loss. Please welcome Dr. Zara Patel.
Hi there, everyone. Thank you so much, Lynn, for that introduction. It's a pleasure to be here, and I hope everyone feels free to think of questions, participate at the end, ask me anything that you want. I'd love to interact with all of you as much as possible at the end here. So what I'm going to do is I'm going to share my screen. And uh, so basically, as Lynn mentioned, I'm going to talk about sinus surgery, and really the key issue about sinus surgery is, how do we make sure it works? So we're going to talk about optimizing these sinus outcomes through expert intervention, because I know, unfortunately, that not all sinus surgeries are equal, and not all patients benefit from sinus surgery the same way. And we can talk a lot about why that is. So here are my disclosures. None are relevant to this talk. So really the key in preventing recalcitrant rhinosinusitis, sinusitis that just will not go away, is to treat it correctly the first time around. And so what I want you to be thinking about as we go through this is, what does it really mean to have exhausted medical management before sinus surgery? Do you always go through a stepwise process and always make sure that your patients have tried particular things before moving to surgery, or are you jumping to surgery? Because you will probably have very different outcomes based on that initial decision. And then thinking about what type of surgery or sinusitis that the patient has. There's so many different things that we have learned over the last decade about phenotypes and endotypes, and we're learning more and more on a molecular level about what causes sinusitis to act differently. So beyond polyps or not polyps, we can think of type 1, type 2. Now we know there's type 3 or mixed type inflammation. Are there eosinophils or not? Does that make a difference? And then, does the endoscopic or CT appearance suggest any other underlying systemic disease factors? There are so many systemic processes that lead to sinusitis or prevent patients from being able to recover once they get a sinusitis, right? Things that affect our immune system, things that affect the mucociliary clearance, the mucus consistency in the sinuses, so many systemic factors that are important to think about when your patient is not acting like the normal sinus patient. And then the real crux of the issue about long-term success is, does the patient understand that this is a chronic inflammatory process? Because I could do the most amazing sinus surgery in the world, but if the patient doesn't understand that they're going to have to continue to manage the inflammatory response that they have in their lining, that surgery doesn't do anything to change their underlying reactivity, well, then we're not going to end up with a successful outcome, regardless of what I do in the operating room. So first, let's talk a little bit about, that first question. What does it mean to treat people correctly medically before moving forward to sinus surgery? There was this study that was done a decade ago now that brought together a lot of experts in the field, and they defined what are the appropriate criteria to move forward with surgery in both chronic sinusitis with polyps and chronic sinusitis without polyps. And they went, together with a bunch of different scenarios in classic sinusitis patients and said, this is what you should treat before you move forward with surgery. You shouldn't move forward with surgery unless you've had this, or you should only do medical therapy and not surgery, or vice versa. But after that study came out, we actually applied those criteria to our patient population here at Stanford. And this is a study we published, just 2 years later. And it's because after looking at their study, I realized so many of the patients that we see here in our practice at a tertiary care academic medical center are really outside the norm. They don't fall under that classic regular run-of-the-mill chronic sinusitis. And the way we address these patients actually deviates from those appropriateness criteria close to a third of the time when we looked at our patient population. And the reason for that is that, they just have specific underlying problems. And that's what gives me the knowledge, the sort of experience and expertise to be able to talk to you about some of those different outside of the run-of-the-mill type of patients. So, what I will say, just to take a step back, is after whatever that appropriate medical therapy may be, whether it's, a course of antibiotics or a course of steroids or just topical steroids for a significant period of time, if patients are not improving, then it is a good idea to move forward with surgery. This is another systematic review and meta-analysis that I published back a decade ago that looked at continuing medical therapy in these medically refractory patients versus surgery. And there was a clear benefit for moving forward with surgery once patients have shown that they are not going to definitively resolve with continued medical therapy. So you shouldn't be afraid of surgery just because you may not have seen it work in the past. It is definitely the next best, most definitive step in treating chronic sinusitis for your patients. It just matters that they get a complete, thorough, meticulous surgery and the appropriate therapy after. So here's just some sort of stats about who will improve with those medical therapies. About half of patients will. And then of those that don't improve, about 60% of those patients choose to move forward with surgery. And then once you do a surgery, it's great, actually. We have an 85 to 90% surgical success rate. But what about that last 10 to 15%? Why are they not resolving? Well, there's a lot of different reasons that I touched on at the beginning, but the main underlying point is that not all sinusitis is one disease. There are these broad different phenotypic categories. Then there are the much more complex endotypes, and we're still discovering the different types of endotypes. And then because of this being truly a chronic inflammatory disease, the need for this long-term postoperative maintenance and care is paramount to having success at the end of that entire treatment pathway and really understanding these underlying mechanisms and comorbidities. And we know that because the frontal sinus is the narrowest drainage pathway and the hardest for us to reach with topical therapy because of gravity and because of the anatomy, that the frontal sinus is the most likely to fail. So I'm going to talk a lot about certain frontal sinus failures and why that might be. But these are other sort of underlying factors that you should start thinking about if you have a patient that either seems to be much more severe than their usual typical chronic sinusitis patient, or if you have had a patient that has undergone surgery and seems to have not improved, or they improved briefly but then relapse very quickly, then you should start thinking about these things: cystic fibrosis, ciliary dyskinesia, this aspirin-exacerbated respiratory disease, which is a very recalcitrant process unless you treat appropriately. And if you do, it can, completely change these patients' lives. Other underlying genetics immunodeficiencies, immunosuppression, and then, of course, things like allergy or undiagnosed dental pathology that is seeding a chronic infection, and then any of the above plus structural predisposing factors. And then, of course, those medical therapies and their ability to undergo other medical therapy. And that's based on both things like allergies or reactivity, but also having to do with insurance access and approval, because that's just a reality in our healthcare system of things that we have to deal with. So the other factors that are really important and sometimes harder for us to talk about are, surgeon or physician factors. It is certainly true that sometimes there is a delay in identifying this underlying disease process, and that will affect outcomes. There is sometimes a delay in referral once that chronic sinusitis has been identified, and we know that patients do much better if they were referred to an expert sinus surgeon as soon as that underlying disease process has been identified. Incomplete medical therapy before moving forward with surgery. Incomplete surgery is probably one of the biggest factors I see as a tertiary care surgeon. And then, unfortunately, surgery that actually creates a worsened disease state because of the scarring or new bone growth that can occur when there has been mucosal trauma or incomplete surgery. So here's an example of a case. You can see this patient, it's a 60-year-old male. He had a sinus surgery at an outside hospital about 6 months before he came to see me. And you can see that, even up in the frontals, there's this inflammatory, reactive, sort of heaped up look to the mucosa. And then as we move down into the ethmoid sinuses, down into the nasal cavity and maxillary sinuses, you can just see that there is disease throughout. And mostly because the ethmoid sinuses have not actually been completely dissected. You can see that there are these residual septations, and you can also see that there's some scarring of the turbinate structure to the sidewall. You can also appreciate that there's actually been this defect created in the roof of the ethmoid sinus, but the cell itself underneath has not been completely opened and drained. And so when you look and see, ooh, into these patients, you see polyp, you see with a 30-degree scope, you can see this recirculation of mucus because they haven't had complete sinus surgery. And just completion of these things, taking this unsnip process down that wasn't removed in the first surgery, taking this polyp and then opening the ethmoids beyond can go a long way. But the actual main question is, what was the medical therapy that that patient actually tried both before and after their surgery? Because if I'm not their initial surgeon, I actually don't know, did they undergo a complete treatment of medical therapy? Have they been tried on appropriate topical therapy? And these are things that you should think about also, not just jumping to a revision surgery, but making sure that you are actually trying all the medical things first again and seeing if they can resolve or not. And so, these are things that are options, and we can talk more at the end if you have specific questions about any of these. I specifically would say the two things that I do not put patients on specifically for chronic sinusitis are colloidal silver or surfactant irrigations like Johnson and Johnson baby shampoo. These are very common things that I see done out in the community, and it's because of, studies that were put out maybe 15, 20 years ago that suggested benefit. But unfortunately, we have seen through other studies since that time that these are actually much more toxic to the lining and can cause things like irreversible smell loss if you put patients on this. And even uh, sort of startup companies that tried to utilize those initial studies early to come out with products, those have all been removed from the market at this point. So here's just an example of, just completion of surgery. This patient already had surgery elsewhere. You can see they already have an opening into the maxillary sinus, but you can also see this residual unsnit, and it doesn't seem like a lot. It seems like just maybe 5-10 millimeters of mucosa, but you see how after removing that, I'm actually able to access this frontal sinus drainage pathway much better. And you can see that with this, we're able to access and open that frontal sinus in a way that never was before. And really, it's this, drainage of what's trapped up there, just irrigating and removing this residual septations. And some of it can be with through cutting instruments. You saw me using a Hoseman, you saw me using a frontal kerrison. Some of it can be with a microdebrider, a powered debrider here. As long as you understand your anatomy at the skull base, you can use powered instrumentation to move very efficiently through a surgery. But if you're using powered instrumentation in an area where you don't understand the anatomy well, or you don't really know exactly where you are in relation to your skull base or your orbit, of course, those types of instruments can cause a lot more damage. And so, like we saw that little defect in the skull base in the CT preoperatively, that's often how that happens. You just make a move a little deeper with your debrider, and you can go through the skull base quite easily. It's a very thin bone. And so using through cutting instruments closer to the skull base, if you're not familiar with that area, is the best bet for getting complete resection. But also, I would say, of course, we would rather, if people are not comfortable working around the eye or the skull base, it's much better to be conservative and not complete the surgery. But if you are not completing the surgery, it is very likely that the patient will continue to have sinus disease and continue to have sinus symptoms and problems. And so, I would say it's really all about knowing yourself as a surgeon and feeling comfortable to draw a line at which you want to refer outwards, you want to refer elsewhere. And I'm always happy to see patients who have more complex sinus disease or have uh, disease that has recurred or just continues, persists beyond an initial surgery, because I, do operate around the skull base all the time. I do operate around the orbit all the time. And so I'm happy to take on those more challenging cases. You can see that after completing that surgery, then the patient has a really nice wide open sinus cavity on either side. So here's another case, and you can see that the, I would say, underlying process looks a little bit more significant or severe, right? You can see that especially in that second endoscopic picture, the sinuses are opened, but maybe not completely. And even despite being open, they continue to have this heavy crust that sits and looks very irritated and angry. When you look at the scan, you can see that there's these trapped areas of sinuses. There's just this very small left frontal sinus, but no right frontal sinus. And you can see that the sphenoids are also quite small. And even the maxillaries, maybe there's been an opening in the past, but it looks like it maybe hasn't been completely opened, or there's something that is preventing all of this mucus that's sitting in the sinus from getting out. And in a case like this, it's really important to think about those underlying systemic disease processes. This is a classic case of cystic fibrosis. The mucus is not able to get out of those sinuses, even though they were opened, because your lining is not able, the tiny little cilia are not able to move this really, really thick, inspissated mucus out of the sinus, because it's just a different mucus, right? We know that because of that chloride channel defect in cystic fibrosis, it's not that thin, mobile mucus that we usually see. So, the great thing about cystic fibrosis is that these patients now have really great CFTR modulator therapy options, and they have really changed the game as far as, how they do after sinus surgery. We used to think that these patients would need surgery after surgery after surgery. They would always have crusting, but that's not the case when they're on these medications. The other thing is that when you are opening a sinus in cystic fibrosis, you really have to think that the rinse after surgery is going to be doing all of the work for you. You cannot depend on that lining to get the mucus out, and you cannot depend on the tiny little cilia to be able to push the mucus up and over that medial wall of the maxillary sinus. So a mega antrostomy is really important to do in a patient with cystic fibrosis. This is also something that we often do in patients with primary ciliary dyskinesia, because you're really wanting to lower that entire medial wall down to the nasal floor, so that then after surgery, even if the patient is not a candidate for those CFTR modulating agents, which not all cystic fibrosis patients are, you still will be able to get a much better outcome because you have brought that medial wall all the way down. You see all this mucus that is just sitting at the base of that cheek sinus because the bottom of the maxillary sinus actually goes lower than the nasal floor. And there's no way that that mucus is going to be able to get up and over that huge wall without doing this type of procedure. So really, getting into all these little mucus pockets, that's another very classic thing that happens with cystic fibrosis, mucus trapping underneath the mucosal lining. So making sure you open all of those pockets within the maxillary wall. And this is the type of sinus outcome that you can have even in a cystic fibrosis patient. You can see it's pristine, the lining looks beautiful, and there's no mucus or crust left in that maxillary sinus. And that's really due to a combination of good, complete, thorough surgery that's directed to the specific disease process combined with that CFTR modulating therapy. So similarly, if you're thinking about immunodeficiency and autoimmune workups, these are other things that you should be ordering in your patients. Again, if you've done a surgery and patients don't seem to be doing well, these are other labs that you can order, really looking for both immunodeficiency as well as autoimmune processes that might prolong that inflammatory process. So I've done a little bit of research in immunosuppressed patient populations because I realized after I'd gone through my training, I trained my medical school in Portland, Oregon, my residency at Mount Sinai in New York, and then I did fellowship here. And my first job after all that training was at Emory in Atlanta. And I realized that at all these different institutions, my colleagues were treating the immunosuppressed or immunodeficient patient population in very different ways. Sorry. And not having a good algorithm as far as how to treat these patients meant that we weren't necessarily knowing that we were getting the best outcomes. So I actually did a, a study to see, looking retrospectively, what was the best way of treating these patients? Just medical therapy or just surgery or combined? And you can see that when you looked at these patients looking backwards, that really the one component that seemed to make a big difference in resolving the underlying disease in the sinuses was surgery. So even when you combined the antibiotics and surgery, you still had a lot of patients with continued disease. Surgery is the one determining factor. And then we actually looked at a different patient population because now we have all of these autoimmune disease treating drugs that purposefully suppress the immune system. And you're seeing a lot of patients like that now. Anyone with psoriatic arthritis, anyone with rheumatoid arthritis, anyone with inflammatory bowel disease, there's so many different patients are on immunosuppressant medications. And we actually saw the exact same thing that upfront surgery was the key determining factor in being able to resolve sinusitis and improve sinusitis related quality of life outcomes in this patient population. So, there's multiple reasons for failure. These are other things that are maybe more surgery related. You see, there's scarring sometimes that happens with the turbinates. There's neosteogenesis that can happen, and of course, just recurrent polyposis. So, when we think of why would we extend a frontal sinus outflow surgery to be more of like a draft 3, recalcitrant frontal disease, extensive frontal mucoceles, if someone had a prior osteoplastic flap and failed that, certainly for tumors, we're doing these surgeries, and then for really complicated fractures that are in that area. But you don't necessarily have to go all the way every single time. So all the way, for those of you that aren't always doing this extended type of surgery, means a draft 3. That means combining, drilling out both frontal sinuses and combining them into one unified drainage pathway, which can be really helpful for people. But we actually have done some studies looking at distribution of nasal irrigation and then the morbidity that follows that type of extended frontal type of approach. And you can actually sometimes just do a draft 2B, which means, removing the attachment of the middle turbinate, bringing the floor over to the septum, but not actually having to connect all the way. So here's another patient that had this surgery at an outside hospital about 6 months before coming to see me. And you can see that actually the rest of their sinuses look great, but the frontal sinus remains blocked. And you can see it's because of this lateralization of the middle turbinate, the scarring that has happened. And so here you can see it's actually quite simple to simply take this scarring, this very superior aspect of the middle turbinate, and go through that. This is a kerosene instrument, a frontal kerosene instrument that I'm using. Now you can actually already see into the frontal sinus, but we haven't brought it all the way over to that midline. And bringing it over to the midline is really the key point, because you can see once we remove that superior attachment of the middle turbinate, we've opened into this entirely other different cell. That's an intersinus septal cell. And that was actually the nidus for this chronic continued inflammation and infection. And once you bring that all the way over, you have a chance of having this heal really nicely and remain open and be successful. So, the main reason I think that a lot of people do not end up opening their frontal sinus correctly is that they don't actually know whether they're in the frontal sinus or not. There are so many superior ethmoid cells that can trick you, and you might think you're in the frontal in a big superior ethmoid cell, but you never actually ended up opening your frontal. So here's a publication that we did based on anatomic findings. Dr. Nayak and I were co-senior authors of this study. He really gets excited about the frontal bar, and I get really excited about the horizon sign. And I'll show you why I'm more excited about the horizon sign. I'll show you that in this picture, the horizon sign is really this very acute meeting point of the posterior table and the anterior table of the frontal sinus that creates this shadow that you can see. And that's really like if you imagine looking across, the earth from a really high up vantage point, and you can see that curvature of the earth and the shadow that tends to be behind it. That's really what you see in the frontal sinus. And you can see over here in this table, this has 100% sensitivity and specificity to show you that you are in the frontal sinus in every single patient. So this is the landmark that I use to confirm that I'm there. And then once I'm there, the other reason that I feel like a lot of people don't completely dissect open the frontal sinus is you're worried about injury to the anterior ethmoidal artery. Of course, it's right there. It's right there at the frontal recess. And a lot of people leave these residual cells at the skull base because they're worried about a complication, like having that artery retract into the eye and getting a retrobulbar hematoma, causing visual issues. And those are definitely really important things to think about, and make sure that you understand the anatomy when you're operating this area. But I'm going to show you this really, really great landmark again to identify the anterior ethmoid artery. And that's once you have opened into the frontal sinus. If you're staying all the way anterior, going up to the frontal sinus, you don't have to worry about the artery going up to it. And then you start operating back along the skull base. And when you do that, you can see that it's always one step back from the beginning of the posterior table, one step back from that, either in a septation or a ridge hanging off of the skull base. That is where your anterior ethmoid artery is going to be. We did this study and used over 100 patients to prove this, used our navigation as our gold standard. And in over 97% of patients, it was always in that septation. And in that last less than 2% of patients that it wasn't, it was within 1 millimeter of that landmark. So this is a very consistent landmark. Even if your navigation breaks, you should be able to identify where this is. And then finally, talking about how to prevent that post-operative scarring, right? You can do surgery really well, but you can still end up with scarring. And there's lots of different reasons why people end up with this. Ooh. But it's the most common minor complication after endoscopic surgery. So this is just showing you what I do. I don't use any packing. I don't use any stents or splints because I feel like those are very uncomfortable for the patient. And I just have them start rinsing directly right away after surgery. But in order to get that rinse really in and out of the sinus as well, you don't want a lot of packing in there, preventing it from getting blood clot out. You're really preventing the immediate healing of the sinus lining if you're putting packing in there. But you do want to prevent that scarring, right? You do want to prevent that lateralization of the middle turbinates. And so this very simple lasso suture, bringing the middle turbinates back to the middle of the sinus cavity, And this dissolves within, 2 to 3 weeks after surgery. So this is very different than the sort of traditional bowdlerization technique that some of you may have learned or heard about, that actual purposeful scarring of middle turbinate to the septum to keep it over. You do not want to do that. I've seen a lot of patients in my smell clinic that have prolonged and permanent loss of smell because of that scarring procedure. So you don't want to do that. You just want to temporarily, during the healing period, medialize the middle turbinates so that they don't scar laterally. This is another example of someone who had had so many sinus surgeries before they came to see me. And this is an example of, what about when you're considering a balloon? Well, it's very, very rare, honestly, that I do a balloon just because of my patient population. I don't really see that many patients who just need a little something here or there. This is someone who had had a sinus surgery again elsewhere, and when I had first saw them, there was still a tiny little opening into this frontal sinus on the left side. But when they came back for the balloon procedure, that opening was gone. And so here you can see me kind of poking and probing along this frontal recess area, trying to find, is this just mucosal swelling that has swollen over the drainage pathway that I saw at that last visit? I eventually, find the actual frontal sinus pathway where it's supposed to be, and I say, okay, I'm just going to go ahead and deploy the balloon into this area. Maybe this is just a lot of, swelling that I can't actually pass this balloon through. But it's not just swelling. You can see that there's such rapid and progressive neo-osteogenesis, true bony closure of this sinus. And so that balloon probe just comes right back down at me. So this is truly an indication for a draft 3 procedure. You can see me looking into the other frontal sinus side, really nice and open, just a touch of edema there, but really overall nice and open. Here's that frontal sinus that I had initially tried to, balloon. And now you can see me again taking that top part of the middle turbinate and having made my septectomy from one side to the other. Now you can see me drilling from side to side. And what's really important when you're doing a draft 3 is not going posterior as much as possible. You really want to open into all of these loculated, areas, mucoceles, and really take down all of the neosteogenesis. But you see how I'm really sticking to that anterior wall. I'm leaving this quite large keel over the cribiform because I don't want to ruin this patient's olfaction, their the ability to smell and taste, and I don't want to get a CSF leak. And either of those are possible when you go more posterior. So in the interest of time, I'll move this along, show you taking this all the way up, and now I'm just placing a steroid-eluting stent that will help this heal without scar. And then finally, showing you a last case where there's really no reason to end up doing a draft 3. You think you might have to because of how tall the sinus disease is within the frontal sinus and how high these frontal cells, these ethmoid cells, are going up into the frontal sinus. You can see that specifically well here. But, going in and just showing you that meticulous, delicate surgery. I'm just going to skip through this a bit in the interest of time so we can get Dr. Most on. That really allows you to take down these septations. You can see I'm using a lot of different instruments, grasping instruments to delicately bring these little cells and septations down from the frontal sinus. And I don't have to drill. And that really allows for a much more rapid healing time. And I still, although, this is meticulous and delicate surgery, I'm still getting a complete wide opening into that frontal sinus. And that's really what you want. You want someone who has all the instruments, the technical know-how. And then finally, if you ever have someone like this, so the goose egg, no amount of endoscopic surgery is going to get this out. You can see this is a guy who had a prior MVA many years ago and then multiple surgeries to try to reconstruct his frontal wall. You can see there's a plate there and something going on. And this is where, you really have to keep your open skill set sharp. This is a bicoronal and getting out this crazy titanium mesh and methyl methacrylate and looks like a sort of dead fat that's been put in the sinus. And once you have this open and you actually do a procedure from below to open it completely as a good drainage pathway, you don't need an obliteration. You just need an open drainage pathway. And this is how this guy ended up. So keeping in mind that, thinking about all the medical and surgical ways that you can get a good outcome. This is my Instagram and LinkedIn if you want to connect, and I'll hand this back to Lynn. And if Dr. Mose is here, maybe we can go to him, but if not, I'm happy to take questions now.
Yes, Dr. Most is wrapping up surgery and trying to make it. So if you wouldn't mind answering a few questions, that would be great. There is one in the Q&A, and then we also have the ones that I sent to you.
Okay, let's see here. Let me go to the Q&A. So this question is, how often do patients with cystic fibrosis that have a mega antrostomy done need to do irrigations? And do you do it in the office? So you don't need to irrigate in the office. This is something that patients just do on their own with, a simple sinus squeeze bottle. They should be doing this twice a day, every single day, and that should just be their long-term regimen. That's basically you're depending on the mechanical clearance of a rinse because you cannot depend on their own tiny little microscopic cilia to move that mucus along for them. And so, uh, you know, there's lots of different things that you can put in a rinse, like a topical steroid, topical antibiotics, and those are particularly helpful for cystic fibrosis patients who have developed many resistances to antibiotics, or they've developed allergies, or they have really severe gastrointestinal issues because of all the antibiotics they've been on throughout their lifetimes. Topical antibiotics in that patient population can be very, very helpful. Topical antibiotics in a normal run-of-the-mill CRS, not typically something that we recommend or do, but for these patients with significant underlying disease factors, it can be really helpful. So uh, let's see, let's go to, uh, can you please talk about your last case? How complex is the case? So, you know, that's a hard question for me to answer about how complex it is because I'm a rhinologist and a skull-based surgeon, and so this is really all the surgery I do. I don't do any other type of ENT surgery. I'm not operating in the ears, I'm not operating in the throat. And so what that means is that the complexity of surgery I do in the sinus and skull base tends to be quite high, but that tends to be quite easy for me because that's all I do all the time. And so, I would say that overall, it is quite complex for someone who is not doing frontal sinus surgery all the time, every OR, like multiple ORs. Then that might be a case that you want to send to someone like me who, is more facile, has all of these really delicate instruments that can do that type of work. So that's that. And so then let me just bring up here the questions that were submitted beforehand, and we'll run through some of those. Lynn, you just interrupt me if Dr. Most joins us. Otherwise, I'll just keep answering questions. Um, so for Dr. Patel, how are the results for PRP nasal injection for anosmia and hyposmia? So, smell loss is not really something I touched on a lot in this talk because it was specifically about sinus surgery. But as some of you may know, I'm also an expert in smell disorders. And, I would say that um, the first randomized controlled trial that I ran was looking at PRP in specifically a COVID-19 smell loss patient population. We randomized patients to two arms. We gave them either PRP injections up high in the nose on the septum at the olfactory epithelium, or we gave them a sham saline injection. And the protocol was 3 injections separated by 2 weeks each. And it was after those 3 injections at the quantitative measure of smell test that was done a month after the third injection that we saw the separation between those two groups. And the PRP arm ended up having a greater than 12 times odds of improving smell versus the saline injection arm. So it did seem quite effective in that patient population. Since that time, I did another long-term follow-up study to see, I wanted to know, was this just improving people temporarily, or was it a long-term gain? And indeed, a year out from those injections, when you looked at patients with PRP versus patients who did not receive PRP, not only was the benefit sustained, but the trajectory of the amount of patients that had benefit actually went up. So we ended up at a year with a 15 times odds of improving your smell after PRP injections compared to the 12 just a month out. And that makes sense because the olfactory neurons have a natural cycle of regeneration. And every 3 to 4 months, a nerve dies off and is repopulated by a new one. And that's not all happening at the same time. And you have 6 to 10 million neurons on either side of the top of your nose. And so it does make sense that you would gain more benefit over several months out from the injections. And now we are actually examining our real-time results. I've injected probably 200 to 300 patients at this point, and so we're going to look to see, how much benefit do people have when they're not in this very controlled study setting with very strict inclusion and exclusion criteria. But I will say the majority of patients anecdotally do respond, although it's different the amount that they respond. Not everybody responds, and some people respond dramatically, and some people respond just a bit. So that's the answer to that one. Um, Another question, what do I think is the most promising recent advancement in rhinology that will significantly improve patient outcomes? It's a great question, and I think there's a lot of different things actually going on. Things at the sort of crux of innovation where people are developing lots of different devices that can do many different things. The way that we treat chronic rhinitis and just chronic runny nose is very different than what we did just 5 years ago. There's a lot of different devices that can target the nerves, but then there's also the new research, just basic anatomic research that shows that the input from the parasympathetic system into the nasal lining is not just coming from the posterior nasal nerve as traditionally thought. There's actually an anterior innervation as well. And so I have changed the way that I've done that procedure when I do an official neurectomy to help people with chronic vasomotor rhinitis. I don't just go directly to the posterior nasal nerves and resect them, but I actually extend that anteriorly now. And we're currently about to launch a randomized controlled trial here at Stanford to look to see if that's making a difference. I would say the addition of biologics that can rescue that last 5 to 10% of patients who just have such a strong underlying inflammatory drive that no matter how good your surgery is, they just continue to create polyps, even when you have them on regular routine topical steroid irrigations. That has been a real game changer. But of course, there are some issues with insurance coverage and the cost of those medications. And so I think both of those are really important new things that we're doing. Let's see what else. Does it deteriorate health in any way? I'm not sure what, I think someone is asking if surgery might deteriorate health in any way. And I would just go back to, the points that I made about, unfortunately, it is true that if you have sinus surgery with a surgeon that is not doing a complete sinus surgery, or they create a lot of mucosal trauma during the surgery, then yes, unfortunately, you can end up worse after surgery than you were before. The same is true if a patient is not willing to continue medical topical therapy after surgery. If they don't understand that's a chronic process and they think that surgery is a magic wand that completely takes away their reactivity, then you might also not have a good outcome. So you really have to think about those things, get the patient to the right surgeon, get the patient the best medical therapy. I think that I just saw Dr. Most pop online, and so although I don't know how much more time we have, maybe I'll stop here, Lynn, and let Sam take it away.
Perfect. Thank you.
Thank you.
Hello, everybody. Sorry.
Hi, Sam.
Oh, I think a lot of you are surgeons, so you know what it's like, but something unplanned happened this morning. Can you hear me okay?
Yes.
Okay. I found a little quiet space in the surgery center here. So Zara, thank you for ad-libbing there for a little while and doing some Q&A. So thanks, Lynn, for the invitation. I was asked to do sort of an update on rhinoplasty, and Right, that's a huge topic. And I'll go ahead and share my screen here. Make sure you guys can see this. Can you see this okay? Thumbs up. Anybody?
Yeah, we can
Okay.
see it.
Okay, good. So it's a huge topic, and there's functional rhinoplasty and aesthetic rhinoplasty, and each subtopic, and it can be a half a day at one of our meetings. So these are my disclosures. So I just thought I'd talk really briefly about evaluation, and then depending on the time, we can talk about what we think is most important that we want to talk about: advances in treatment of the septum, new ways of doing osteotomies, specifically using ultrasonic instrumentation, and finally dorsal hump reduction and crooked nose correction with preservation methods. So maybe we'll even ask folks in the audience what they want. But I think that evaluation is so key. I see so many patients that get referred to me for functional rhinoplasty that have had various things that haven't worked. And I think some of it is just evaluation and making sure we tailor things for our patients. Every rhinoplasty you do is both functional and aesthetic. I mean, I started my career out doing mostly functional rhinoplasties. It's easy to make someone look really bad doing that. And same with aesthetic surgery. It's easy to ruin someone's airway. So you have to really be cognizant of both whenever you do these cases. Just quickly about how I measure things. Some of you out there may do quantitative measurements of nasal airway or airflow. This is an example, for example, from a paper of nasal airflow. The nose questionnaire, as we all know, is a validated problem for breathing, and so a higher score is worse. And nasal peak flow is on the x-axis, and you can imagine that you'd expect it to look something like this, with a sort of a correlative relationship between increasing flow and decreasing nose questionnaire scores. But actually, this is the real data from this paper, which was really a seminal paper for me. This is 20 years old now, but really made me realize that measuring airflow doesn't really correlate necessarily with what our patients are feeling. So I usually use patient-reported outcome measures. I used the nose for many years, and we developed one called the schnoz, which we use in all of our functional and aesthetic rhinoplasty patients. It's really not just an academic exercise. CMS is mandated that if we're doing this type of surgery, we should be using a patient-reported outcome measure in our practices. This is for private physicians or academic. And so I find that it's very useful. I have no financial interest in this, by the way, or the nose questionnaire is something we probably all ought to be using. And when we look at the nasal airway, we're taught the classical things about septal deviations and classifications, and also external valve collapse and internal valve collapse. And for me, the nomenclature, if any of you ever see any of my notes and referrals or anything, is a little different, because I think that classification systems are useless unless they actually guide your clinical decision making. Too many people like me are out there just publishing classification systems for publications that are not really very useful. So when I think about nasal obstruction, I think about the type, and I categorize it as a static or a dynamic. And by the way, I'm not going to get into inflammatory causes. I'm just talking about anatomic issues. And then location, whether it's medial or lateral. So for example, a static medial deviation is your classic septal deviation. A dynamic lateral deviation is lateral wall insufficiency, which is a term that we proposed back in the 2000s and the aughts, and largely has replaced the nomenclature in my practice. I shouldn't say largely, has completely replaced the nomenclature in my practice for external valve collapse, which is what people would say this person has. Classic external valve collapse. This is now called zone 2 lateral wall insufficiency, and it would be a grade 3. And I'll explain that here in a second. We look at lateral wall insufficiency as occurring in 2 zones. Zone 1 is from the scroll up into the upper lateral cartilage. It's usually due to senescence or just weakening of the tissues, and the piriform ligament and so on weakens as we get older. You see this a lot. And then zone 2 collapse is either due to cephalically oriented lower cartilages or iatrogenically due to resection of that the lateral cruce too much. And so we also grade these as 0 to 3. Any of you who are otolaryngologists, which I assume is all of you, recognize this from like, tonsil grading systems, but basically it's the amount of movement, not the position, it's the dynamic movement, 0 to 33%, or sorry, 1 to 33, and so on, up to 2/3 to 1/3. So it's the amount of movement that you get. It really is it's a question of how much the negative pressure generated is overcoming the lateral wall support and causing medial movement. And so we have zones 1 and zone 2, and we treat them differently. We published papers on this, and it's somewhat intuitive, but upper zone 1 collapse is really treated with lateral pearl strut grafts, batten grafts, which I don't like, Latera, and bone anchored sutures, to name a few things. And below, down in zone 2, we treat with rim grafts, repositioning the lateral crus or inferiorly positioned grafts of some kind. And this tends to work very well for these patients. The key is, again, about evaluation. We all feel better when we stick something in our nose or pull on our cheek and pull everything outwards. What I can tell you is I pretty much can't do that. If someone can do that surgically, reliably, to the degree that most practitioners I see doing it do it, then great. But so as far as a litmus test for whether you really should have any sort of lateral wall reconstruction, it's not good. What really you should do is take a curette or a Q-tip and put it in there and just stabilize the lateral wall in the exam room and have the patient inhale through their nose at a normal level, the level that normally causes obstruction. And the patients that respond to that are the ones who really can benefit from all these. This is particularly true of Latera. Now, by the way, I used to be consultant with Spirox. I have no financial interest. I haven't for 8-9 years. And that was part of the original studies that were done. I was very careful to make sure the physicians doing the studies were doing it that way. And so I think the results were actually better that way. So I think it's probably overused a little bit. And just like anything else, if you don't pick the right patients, then it's just not going to work well. So this is really important. Patients, when they breathe in really hard, like me, you're going to get some collapse, so that doesn't really count. It's regular. If they have normal breathing and they collapse, that's pathologic. And if those patients usually respond to lateral wall support in the exam room. With regards to the septum, there are 10 papers probably on classifying septal deviations, and I don't really follow any of those guidelines. To me, what's really most important is where the septal deviation's happening, whether it's anterior in this anterior triangle or posterior to it. And specifically, if it's an inherently bent cartilage, either vertically or horizontally, or whether it's just like a excess that you can do a swinging door on. And so just a quick word about septal deviation. So if they're anterior to this, I do an external extracorporeal approach. If they're posterior, I leave the L strut intact and do your standard septoplasty. I'm just going to review a couple of things, because I see this a lot. I think you really need to leave 1.2 to 1.5 centimeters at the keystone, not 1. You don't need to take anything out up there. It's not causing a problem, so just leave extra. Because saddle noses are, you bought the patient a rib graft. With regards to the L strut, that part can be a centimeter, but the genu, I'm going to skip that one. The genu needs to be not a right angle. I just did a case where this is, a revision where this angle was really sharp and actually they had overcut it, so the whole thing had just warped. There's a lot of tension in that spot, and numerous studies have shown that this right angle is very important when you do your septoplasty. And finally, this is another one I see a lot, is people look at the posterior septal angle, which is the corner of the cartilage, which in this drawing isn't really anterior to the spine, but often is up to a centimeter in front of it. And they go backwards from that and leave a centimeter. You should actually go, have a centimeter over the spine itself. Otherwise, you're not going to have support for the L strut. So these are all really important things to remember. Septoplasty is obviously something we all do, but those are some nuances that you always have to remember when you're doing this. The problem is when patients come in with this, what are you going to do? This patient had actually, I think, had a TSA and the septum had warped. In these cases, you have to replace the septum and you have to do an external approach. If you open up a nose and you see a septum that looks like this, doing an L strut's just not going to work. And I don't like splinting or scoring. I don't think any of those things are really good for the patient, especially the scoring. In the end, it fails structurally. So we published this also in the aughts. You just resect everything except a small portion of cartilage at the top to make it easier to reconstruct the patient with an external approach, and then you rebuild it. And so this is just a drawing. This is actually what I show patients in the clinic so they understand what we're going to do for them. And this is just a little animation kind of showing this. Oh, I guess I have my voice on there. Can you guys hear that?
Yes.
Okay, I'll just shut up for a minute.
Oh, no, Sam, we can't hear
Oh, okay, you can't hear that.
Just
All
hear
right, so
you. Yeah.
there's actually a voice there. So so basically we resect all the cartilage except that dorsal strut, and there's a variable excision area. And so you leave that little stub. The important thing is the way Gubish originally did these, he resected the whole thing. It's really hard to reconstruct the keystone area. So that was sort of the revelation in this. And then you resect all this cartilage, and then you find a straight piece. You need usually about 28 to 32 millimeter straight piece. This is why your cartilage doesn't work well for this in revisions. You need to use rib, but on a primary, you can use the septum. We take this out and then we place it with a notch into the nasal spine and then suture it. And so we're basically recreating the L strut. We've broken the spring of the L strut, taken out the tension on the part that is inherently twisted, and secured it into position. This has been just a workhorse for me. I do it all the time in rhinoplasty surgery and for functional noses. I have no hesitation to do it. And so, if you do external approach rhinoplasty at all, this is really the way to treat these patients the best. And we've looked at our outcomes over 15 years, and it's really been great with a really low revision rate. But it is more. I mean, it is more involved than standard septoplasty, of course, but it's the right way to treat these folks. So this is just showing you in the cardinal line where we do this. So just a little bit about osteotomies now. So these are the tools of the trade when we're doing rhinoplasty, and I think used by most people. And the high-low high osteotomies and medial osteotomies are standard practice. And this is something that I wrote and talked about for a long time. But and this is sort of the technique that we would use. This is on a cadaver. This is an old lo-fi video from like 2003 or something, but showing the typical osteotomy path, and you leave the periosteum intact, which is very important, over the lateral nasal wall. But now we have new instrumentation, the ultrasonic instruments. You see a lot of people marketing this. I actually was probably one of the first facial plastic surgeons to use this back in 2017, 18. I don't really make too big of a deal out of it. Olivier Gerbeau, who's in that picture with me there, is the one who really innovated this idea, or at least popularized it. I think some oral surgeons who were doing rhinoplasty are the ones who really started using it. And I found it gives you so much more control. The difference is you really have to elevate the periosteum over the entire nasal vault when you do this. When they first started marketing it, they started saying that you had dramatic reduction in swelling, that it was impossible to cause flail segments. I don't think those are really true. I definitely think that if you have a willingness to try new technologies, it's a great way to go. And it really does allow you really precise bony contouring and drilling holes and securing things, which really has changed the game. And there's so many tips that have come out over the past 10 years for just about any purpose. In fact, I use the piezo tips now to cut the septum and cut the PPE, the long ones you see on the right. And so it's just offered a tremendous amount of control. So I have no financial interest in this, but if any of you ever have questions about the devices, I'm happy to answer them for you. I have 2 different devices that I use. And like I said, the thing that when you get started is going to be strange because you elevate the periosteum over the entire nasal vault, which was such a big no-no that we taught for standard osteotomies. And just so you know, the rationale is that the mucosa on the inside and the periosteum on the inside is intact, whereas if you use a standard osteotome, you're cutting that. And so the idea is that that gives you some stability. again, you can get flail segments with piezoelectric instruments just like you can with standard. So that isn't really an advantage, but I think just the visualization and control is really, really great with the piezo. Someone had asked before the talk, I think a couple of weeks ago, to talk about crooked nose. And, crooked nose is a huge topic, and it kind of fits under the osteotomy subtopic here. I think the bottom line is that you have to tell patients, if you're doing cosmetic rhinoplasty, that it's impossible to get anyone 100% symmetric. This is a patient who'd come to me for dorsal hump reduction. He was a teenager. We got a scan because I was suspicious of silent sinus. He didn't end up having that, but he had a really asymmetric craniofacial skeleton, which wasn't even that visible. And so this really heightened in my mind the importance of analyzing your patients carefully before you do any sort of crooked nose surgery. Everybody thinks that their nose is perfectly straight until somebody bumps it, and then they think, oh, now, it's all caused by that. Probably they had some baseline asymmetry as well. So if you're doing post-traumatic noses, it's something to counsel patients. And, these are drawings from the book, but, there's so many different nuances for mobilizing the nasal bones. These were done, these types of things I did with osteotomes, but I think with the piezotome, these really precise cuts and things are things you can do much more easily. And so you can move nasal bones in by resecting triangles of bone if they're asymmetric, or you can move nasal bones out by opening up the nasal bony vault and placing spreadografts, as shown in green, to make things look straighter for minor deviations. The septal rotation suture is really nice. And this is when the septum is a little bit deviated. You can actually place this suture, and for subtle deviations of the septum, now this is basically a mattress suture that's slightly offset. So I didn't go straight across. I went a little bit caudally on that graft. That's an ASR graft you see there, by the way, the sutured into place to the dorsal septum. And when I suture this down, you're going to see it's going to pull a little bit to the right. And so subtle things like this you can do. The little nasal bone modifications, or this septal rotation suture that Baumann Geiron in Cleveland came up with, is a great way to do minor adjustments. And this is a diagram of it. But the big show is when you have to move the entire bony vault. And we do sequential osteotomies for that. They call it the open book technique. And I think there's a video here. And this is a video of that with the patient obviously protected for privacy. We do our osteotomy starting on the side we want to move towards, on the lateral side. This is with the old osteotomes. Obviously, this is sped up. So you do your lateral osteotomy. Traditionally you do medial then lateral, but in a crooked nose, you start on the side you want to move towards. You see I put numbers on there for teaching the residents. Number 1. Number 2 is here that we're going to push that bone over. I'm pushing it over. Sorry, it switches from top to bottom here. Then we're going to do the other medial osteotomy, then finally the last lateral, and move the whole bony vault over. I'll show you preservation methods here next, because I think that's really a paradigm shift in terms of how we treat crooked noses. Traditional dorsal hump, so that was kind of just a little bit about osteotomies and using the ultrasonic instruments. Now, traditional hump reduction is we cut the top off the dorsum. This is Jock Joseph's method, and you do osteotomies medial then lateral, and then reconstruct the mid vault. So just to orient you, the cross section on the left shows you where we're looking at on the right. The problem is people get asymmetric. One of the problems, I should say, is people can end up with asymmetric dorsums because the dorsal septum might have a bigger gap on one side or the other, and the bone will fall in a little bit more on one side. And so preservation methods have been around for 100+ years. They just weren't really very popularized until the last 10. And Maurice Caudle is one of the people who kept this technique alive all through the 20th century. Here, the concept is you don't cut the bones at the top at all. You leave the bridge completely intact, dorsum intact. You cut in the midface and the septum, and you basically push the whole thing down, which is just conceptually kind of mind-blowing, but it works. You can actually flatten the bridge like this. This is an animation showing this. These are the cuts you make in the bone, and then the whole thing sort of flattens down. This is the cut we make in the bone. This is a cadaver specimen. This is the bone removed, now I'll show you what we do with the septum. We actually will make cuts like this. This is a methodology that I published in 2019. And then you flatten the septum. You can see how this is going to work. See how that split underneath opens up and the whole thing sort of lengthens and flattens. And this is what it's like when you suture it down. And so this is the paper. This is an open access paper. I did that on purpose so people would be able to get it. And another animation kind of showing what we're doing on this. So we preserve this caudal strata septum. We resect some septum in the dorsum for the correlates to the amount we want to drop it. We put a vertical cut in the flexion segment. We do an osteotomy at the radix. Now we've done the lateral osteotomies and resection already, and then the whole thing sort of flattens down, sort of like magic. And so for crooked noses, you can actually now, instead of cutting all those bones, take the whole thing and shift it over. So for a minor axis deviation, if somebody's just a little bit off, you can do this procedure and simply take that flap of cartilage of the septum and put it on one side or the other and actually make them look straighter. So this is for minor deviations. This is something that we used to try to put little spreader grafts in and all this kind of stuff, but you can keep the whole bridge intact and just shift it over with this method. And it works really well. For really deviated noses, I think it's even better because here what you can do is, one of the challenges of standard rhinoplasty for this is making the nasal bones the same length. You can see one's a lot longer than the other. What we're going to do in this case is just cut one side, resect bone so that they're of equivalent length. We actually measure it in the OR first, do a little overlap on the dorsum, and then the whole thing just sort of rocks into position. When we're preserving, these dorsums, why are we doing this? Because the natural architecture with that slight shoulder and curvature to the bridge is it's hard to reconstruct. And we do it all the time for experience with structural conventional hump resection, but it's nice to preserve these patients. When you preserve their dorsum, they look so much more natural. And so whereas in the past we had really no choice, we just did conventional hump resection on all our patients, now we have a choice. Do you preserve the dorsal architecture or not? And we do entire conferences on dorsal preservation. So I'm sure you probably have some questions, but it's a complex topic. But preserving that dorsal architecture is so nice when you can do it for your patients. I don't think you have to do it on everybody, but you should do it whenever possible. And this is part of a lot of the teaching that I do now internationally on rhinoplasty is when to make the decision to do preservation or not. And so I think that, the key is what I tell the residents and the fellows is at some point, technically, you're as good as you need to be. Honestly, it's really your ability to make decisions about patient evaluation, functional aesthetic, making decisions about which technique you're going to use to do an airway reconstruction or reconstruct the septum or do a dorsal hump reduction, for example, that makes you an excellent surgeon and separates you from a good surgeon. And so we're not always right, but I think the more right we can be, the better our patients will be. So that was just a quick overview. I wanted to talk a little bit about the ultrasonic instruments, using those in osteotomies, septum surgery, introduce you to preservation rhinoplasty if you've never heard of that before, and just a little bit about how I evaluate patients. Again, I apologize because I had a sort of emergent thing that came up, but I appreciate your time. And Lynn, thanks for having me, and sorry for being late.
Thank you, Dr. Mose. Thank you, everyone. The recording will be emailed within 10 days, and then you will receive the CME evaluation so you can claim your credits within 7 business days. Have a great rest of the afternoon, everyone. Bye-bye.
Bye-bye.